click record because I know some people had said that they would like it recorded. So if anybody does have a colleague who wanted to have listened to this and couldn't, then we are on record. So welcome to the first South Hardwick PCN free access medical education evening. And so big thanks to Pauline, whose idea this actually was, Pauline Miller, and Pauline and I decided a few weeks ago that we were a little bit bored of the fact that we weren't learning anything. And it's not that coronavirus isn't really interesting and exciting and any of those other things, but we've done hours. I mean, fortunately, appraisal's been suspended, but I reckon if I'd written up what I've learned about COVID over the last 3 or 4 months, it was probably, you know, totaling in the hundreds of hours. But actually, there's all sorts of other medicine that's important not to forget about. And particularly because we've changed the way we're working so much and doing so much remote working, that actually sort of feeling skin in particular and being sent pictures of rashes feels like a significant proportion of what we're doing at the moment. So at least I don't know if that's true in everybody else's practice, but certainly for me, I feel like there's endless e-consults of rashes that are being sent in, and acute rashes, and certainly a number of my trainees had got a bit stuck. So this kind of started off as something I did for them, and then have done for a couple of other groups, and people have said that they thought it worked reasonably well. So my apologies if it doesn't, but I'm hoping we'll have a bit of a refresher and a good think about rashes. So what we're going to do is ping up to our screen share, a slide share, and hopefully can you all now see a title slide, dermatology stuff? Yeah.
Yeah.
Good stuff. Awesome.
Yeah.
So, thank you. So and it's just really thinking about, this is a bit of a whistle stop tour, and it's some acute rashes and stuff that you might well see on a sort of like e-consult type stuff, or pictures, and we're very much talking acute rashes rather than chronic dermatology. I mean, dermatology is absolutely vast, so we're really sticking at, I've got this rash and it came on 3 days ago, doctor. I've got this rash and I've had it for a week. I've got this rash and it started this morning and it's really spreading today. That sort of a rash, rather than I've had this thing for 6 months and I don't know what it is type presentations. So yeah, thanks for coming. So what we're going to do tonight, obviously, is me, dermatology. We kind of had an idea, so hopefully, you know, you're all here, which is great. People are enthusiastic about learning. I had an idea about trying to make this something that happens fairly regularly. And with the hope that actually working collectively across the PCN, people might want to volunteer to run some sessions. So practices could take on some sessions and nominate somebody to run something, or find a friend that is a friendly cardiologist or whatever to come and do it. I'm quite a passionate believer in sort of free access medical education and sort of no free lunch, not being sponsored, just trying to do this ethically and sharing and collaborating and working together as much as we can. But if people have got things they would like to see on the programme, that's great. If you want to let me know things that you would be keen to deliver, that would be great as well. So, you know, email me if you've got any topics. Thought the next time, because it's come up loads that people wanted, was HRT for beginners and in need of revision. So next time's going to be HRT. And then I can't remember whether it's August or September. Somebody will have to bear with me. Steve Lloyd has agreed with Duncan Gooch and Sid Chawla to talk about three-letter acronyms in 2020 NHS. What do they mean for me and my patients? Try and make some sense of some of the stuff that might be going on, and some of those acronyms and things. So a few do's and don'ts, which I hope are really self-explanatory, but I'm just kind of going to go through. So if you're trying to keep your microphone on mute unless you're actually talking, Make sure you're dressed appropriately. Most people have got their cameras off, so it doesn't matter. Unfortunately, after a colleague had an incident with a participant who didn't have any pants on, I actually feel compelled to point out that that's not okay, because actually it's quite hard if somebody just sort of stands up for a stretch and you realise that they're like half naked, and that's not okay. And I thought that went without saying, but you know, it clearly doesn't. Yeah, join in if you want to. Really helpful to know who's here. So, you know, calling names and surnames on the screen. And as I said, if you stick your name and email address on the chat, then we can send you out some things by email afterwards. And yeah, please join in. There's not that many of us. We're going to mostly join in by sticking stuff on the chat, sort of like spot diagnoses. What do you think this is? That sort of thing. So yeah, please join in. And yeah, just join in, have fun. Don't be scared of trying out new technology. I know using this sort of medical education is a bit different for a lot of people. So hopefully it's going to work for you. If it's probably can't be anybody's first Zoom meeting, but maybe it is. And let me know what you think. So there is a Survey Monkey that I'm going to send out at the end, and there's a QR code to snap on the slides if you want to snap it and do your feedback straight off at the end. Because it would be really useful to know, is this useful? Shall we carry on doing it? Or was this a nice idea to try and actually a bit of a disaster? So dermatology. So caveat, so I'm Tara George, I am a GP, I'm a GP trainer, I work at Wingerworth, I have been a GP since 2005, which actually makes me suddenly feel quite old, but I am not a dermatologist, I'm not a GPSI, and I am probably the least visual person in the world. And dermatology is a really visual specialty. So that actually is often a bit of a problem. So I think it's just worth thinking about. If you are a really visual person, dermatology is quite easy because you build up this image bank in your head. But actually, if you're not a visual person, it can often feel really, really stressful. And my kind of top tip for that is actually, if you get very good at the wordy bits of nomenclature and start describing lesions to yourself, like, oh, it's a brownish macule, that, you know, that it's a solitary lesion, any of those other things, that actually I'm much more likely to be able to describe something to myself and trigger off a textbook description than I ever am to recognize anything from a picture. And people who are visual find that very weird. And because most dermatology teaching is done by people who are very, very visual, it can often feel incredibly disheartening if you're not visual. So that was just something to think about. And history obviously is really important. But I'm kind of sticking with this whole, they sent it on an e-consult and it kind of says, I have a rash, I want you to help me with it, with no history. And you may well end up needing to ring them and find out more, but it's those kind of spot diagnoses that we're thinking about. And I'm hoping you'll have come across the majority of these before, so there shouldn't be too much that is completely new. So what we're going to do is there's going to be some pictures, a little bit of talking about what they might be, and stick some things on the chat. If I'm asking questions, stick it on the chat, stick your answers on the chat, and we'll kind of talk through, and then we'll have a look at the answers and some learning points. Just worth remembering, my personal go-to 3 sites, which are DermNet, the British Association of Dermatology, who have the most amazing patient leaflets. So if you take nothing away from tonight, except that actually BAD have got the best leaflets ever, then, you know, they're really, really worth looking at. And of course, with stuff like AccuRx, you can just send them, link them brilliantly easily, send them across to your patients. So definitely worth having. And the Primary Care Dermatology Society is great too. DermNet's brilliant, but it's from New Zealand. So just sometimes there's stuff in their treatment recommendations that are outside what NICE would recommend or totally off our formulary, where BAD and the PCDS are UK based. So sometimes a bit easier, particularly with prescribing, to follow their guidelines. So hopefully we are all ready for some pictures. So going to start you off with something that hopefully is nice and easy, straightforward, gestalt sort of a diagnosis. So imagine you've got an e-consult with probably any one of those pictures, because they'd be a bit unfortunate to have it in 3 places, though that's not completely impossible. So if you have any idea what you think that might be, do you want to stick it on to the chat now? Brilliant. Everybody's saying impetigo, fabulous. So yeah, impetigo. So nice, straightforward, easy one to start off with, I hope. And you've got your kind of golden crusty lesions, caused by Staph aureus, which obviously aureum means gold, your golden crusty lesions. And just worth thinking, strep A can also give you impetigo. It's mostly staph, but you can get some strep as well. Commoner in children than in adults, and weirdly boys more than girls. Are boys just dirty? Who knows? Why do boys get impetigo more? Are they sweatier? Nobody really knows. It's commoner in the summer. And of course, we're probably going to see tons less because kids aren't in contact with each other. And because skin trauma and skin contact are the two things that are most likely to make you get it, we probably have seen a lot less this spring and will this summer whilst everybody's very distanced. Just worth thinking, you know, you want to treat it because of complications. And most of the time it's just a horrible lesion that won't settle. But you just want to be mindful. Obviously, it's staph. You can go on to get scalded skin. And I just think, going back to that picture, this armpit lesion does look a bit scalded around the edge, doesn't it? Which is where you start going, okay, golden crusty lesion, that kind of peeling, kind of burnt look, where that's a lot more classical with that kind of yellow crusty patch. You can go on to get cellulitis. Any infection can give you sepsis, and particularly if you've got group A strep, just worth being aware, of course, you may go on, you know, kids can go on and get glomerulonephritis, so, you know, important to treat. And it's also worth remembering that staph love warm, damp places to live. So flannels, towels, pillowcases. So it's a real time to actually remind them to hot wash everything they've been in contact with. And the kids are meant to be kept off school for 24 hours. If they keep on getting if they keep on getting impetigo, it can be worth using a course of an antibacterial up their nose to eradicate staph carriage, because often it is they've got excessive amount of staph up their nose, they're picking their nose, they're rubbing it everywhere and reinfecting themselves. And NICE have got some really good guidelines. These came out last year, and I just think some NICE this year, sorry, February 2020, and some NICE guidelines are helpful, aren't they? And some of them are a little bit less useful. I think this is one of those ones that's got a really clear treatment summary. So it's just worth having a look at. Though, fascinatingly, it would be interesting actually on a show of hands. NICE recommend topical hydrogen peroxide cream. It says, which is interesting because I have never prescribed topical hydrogen peroxide cream, nor has anybody else that I have ever spoken to. I don't even know how you'd prescribe it. So if it then says if hydrogen peroxide is unsuitable, and we did decide that perhaps is unsuitable meant if you actually have no idea what it is or how to get hold of it, then go on to the next thing. But it's just, you know, that's worth thinking about, that's what they say. And, you know, it goes through choices for adults, choices for children, doses and things like that. So I think that is actually a really, really helpful, nice visual summary. So picture number 2. So again, these are 3 pictures of the same thing. Any thoughts? You want to stick on chat what you think it might be? And each condition appears only once. So if you're looking at it going, oh, that looks like impetigo, it's not impetigo because we've done impetigo, we've moved on. Brilliant. So most people have got this. So this is herpes simplex, HSV. And just having a look, I suppose that looks very classically blistery herpetiform, doesn't it? But the thing that people often get confused by, and when herpes simplex often gets missed, is when it's not on a mucous membrane, because it's more common to get it on mucous membranes, but they don't have to be on mucous membranes. So here we've got a herpetic whitlow on a finger. Here we've got a child with quite marked lesions on their face. And so it can look almost quite bacterial, can look a bit like impetigo, and you can get lesions and recurrences. So I've had a few patients who've had recurrent herpes simplex on their arms, on their legs, on their trunk. And I think it's just that whole thing about thinking, if it looks like a little crop of blisters and it's recurrent in the same place, it's almost certainly a hepatic lesion of some sort. Just having a look at the next picture. Anybody know what that is? So this is related. This is the same thing. Anybody know what that's called? Nope. Lots of quiet. So that is hepatic gingivostomatitis. Classically seen, now this looks like this may be an adult. The times you tend to see it in people who are really significantly immunosuppressed, who then go on to get HSV. So people who are having chemo, people on massively high doses of steroids. But kids with primary HSV can present like this. I've seen 2 or 3 of them in my time as a GP. So it's not common, but I think once you've seen them, you never forget them, because they come in and they are so distressed and drooling, and they just won't eat or drink, because of course they won't eat or drink, because they've got horrific ulceration, of their mouths and of their lips. And, they sometimes even end up getting admitted and end up, with NG fluids and all sorts. So just worth being mindful of. But, clearly if you see that in an adult, having a really good think about, is this person immunosuppressed? What on earth else is going on? But as I say, in kids, when they kind of go, oh, they've got this cold sorey thing around their mouth, but they're really sad and they won't eat and drink, I think sometimes there's a sense from us to go, what do you mean they won't eat and drink? Oh, for goodness sake, man up, give them some Ribena. And then you see them and you just go, oh my goodness gracious me, no wonder you don't want to eat and drink. So just a little bit about HSV. So we've always kind of said, oh, HSV1 is cold sores and HSV2 is genital. And actually that's not really borne out in practice. The vast majority of herpes that we see is HSV1. We've already talked about, so primary HSV and hepatic gingivostomatitis can get really dehydrated. So that's just worth being aware. It's infectious 7 to 12 days and incubating for 2 to 12 days beforehand. It's very much a clinical diagnosis. Just worth though being aware, if they've got ophthalmic involvement, they do need an ophthalmology review, because you can get corneal damage, dendritic ulcers, eyeball perforation, all sorts of horridness. So if you think somebody has got a cold sore in or around their eye, you are supposed to speak to ophthalmology on the day. And interestingly, one of the things I suppose we probably aren't going to see this year is those people who come and they say, oh, it's really weird, whenever I go on holiday I get cold sores, it's so weird, maybe it's because I'm so run down and then I really needed the holiday and it's all the stress coming out. But it's actually probably the UV light that's the problem. So UV is quite a potent trigger, so depending on where they get it, actually really significant sunblock and wearing a hat might make a big difference. And it's just remembering it's acyclovir 200 milligrams 5 times a day for treating HSV, because I think, again, it's one of those things that I often end up having to look up the acyclovir doses for different things. So if it's HSV, it's 200 5 times a day. So just a little note on genital herpes. I always swab them. I don't know about anybody else, whether other people do always swab the first kind of episode of genital herpes. I always do, simply because if they've got HSV1, you can be really relatively reassuring and say, well, do you get cold sores? It's probably auto-inoculation from your own hands. You're relatively unlikely to get a recurrence, don't worry. Where actually, if they've got HSV2, I mean, their stress is always, oh my goodness, where have I got this from? Oh my goodness, I've got herpes. Oh my goodness, my life is over. But actually what I'm much more interested in is, what is the risk of recurrence? And actually, if they've got HSV2, actually talking to them about the fact that this is quite likely to be a recurrent problem, I think can be really helpful. And just worth as a reminder with genital herpes, that they will often present with inguinal lymphadenitis. So they'll often present with really, really sore groin lymph nodes. They can end up presenting with more of a discharge, and particularly an anal discharge in men who have sex with men. So that's just, again, we're thinking about if you've actually got sort of perianal genital herpes or rectal genital herpes. And in primary presentation, they can be bilateral. So if it looks like herpes, but it's both sides, it doesn't mean it isn't. It's more common to be unilateral, but it's not totally always unilateral. And they can often feel really quite fluey and quite unwell. So management wise, the psychological stuff is probably the most important, and the sort of topical lifestyle stuff. So support, reassurance, saline bathing, lidocaine gel, or instiller gel actually before they're weeing, because the main problem, what is the commonest, day-to-day inconvenient complication or frustrating complication of genital herpes? Anybody know? I'm slightly laughing because I know there's 2 people here who've seen these slides, but there are 3 people here who've seen these slides before, so I will be fascinated to know whether anybody can remember. So dysuria is a common presenting feature, but the dysuria can lead to something else. Retention, absolutely. Retention. So just worth thinking about it, because again, we often miss genital herpes because it's a woman who says, it really hurts when I pee. Oh, it's so sore, doctor. Oh, it's awful. It's just stinging. And we go, oh, brilliant, you've got a UTI. But actually we say, are you going more often than normal? No, I've not gone for about 12 hours. It hurt so much last time. I'm just hanging on. I just can't bear it. I don't know what to do, doctor. I'm busting, but I'm too scared to go. If you've got cystitis, you are highly unlikely to be able to hold on and stop yourself going to the loo. So actually, if they are presenting with some kind of dysuria, non-specifically not quite right, have a fairly low threshold for thinking, actually, could this be genital herpes? Because if they haven't got frequency and they haven't got urgency, they probably haven't got cystitis. And I think these are often the ones that we miss and treat them as a UTI and they don't get better. And again, symptomatic treatment, pouring water over their genitals when they're, particularly for women, actually saying, okay, pouring a jug of water over, or weeing in the bath. Now, again, when I was a gynae SHO, I was horrified by the number of women we catheterized in retention with genital herpes who'd been suggested that they weed in the bath and they thought that was disgusting, but then came and had a catheter. So again, I think there's no accounting for what people think is normal or not normal, but it's just worth thinking about because actually you probably can avoid a really horrible, embarrassing admission to hospital for a catheter. And interestingly, again, so the guidelines again for genital herpes, the BNF says 200 milligrams of acyclovir 5 times a day. BASH, the British Association for the Study of Sexual Health, say actually you actually can do 400 milligrams TDS for 5 days instead, and that's probably easier for people to remember to take. So the BASH guidelines for genital herpes are, I think, really, really useful, and that's just worth thinking about. That actually you're probably going to get better concordance than the 5 times a day with the 200. So moving on to something completely different. What have we got here? Again, if you think you know, stick it on the chat. Yeah, brilliant. So a few people have said, yeah, so folliculitis. So you've got these little pustules here, and you can see the little hair shaft, can't you, in those lesions? I quite like this really close-up picture from DermNet. That's the other thing I love about DermNet, is that you can use their slides and they're really happy. They've all got these little watermarks on them, so that you have to credit where they're from, but they very much say as long as you keep the watermark on, they're really, really happy for their images to be used in teaching. So again, I think they're an amazing, amazing resource. So folliculitis, again, it's mostly staph. And if they're really deep, you get boils. If they're superficial, it's more folliculitis. And generally speaking, thinking about topical antibiotic or antiseptic, and occasionally oral antibiotic, usually flu clogs. And just worth mentioning hot tub folliculitis, which is more likely to be Pseudomonas. And that's just worth thinking about it, and particularly in this weather. We had a very unfortunate situation with a family a few weeks ago who all gave themselves hot tub folliculitis because they bought a hot tub on a whim when they'd gone out to the garden centre because it was out of lockdown, and they bought a hot tub and they didn't have any chemicals, but they filled it up and used it for a few days, and they all presented with Pseudomonas. So it was quite unpleasant, and just worth being mindful of. Okay, so What about this one? Any thoughts? Chat's gone very quiet. Yeah. Oh no, Hannah, you've spelt it right. You spelt it right. Yeah, so folliculitis barbae. So a variant of folliculitis in the beard area, almost inevitably seen in men. And so it's almost always related to shaving. So again, it's staph, and it's usually to do with a bit of trauma to the skin. But just worth being aware, you can get really marked scarring and hypertrophy, and particularly in black skin. You can get awful keloid formation as a result of it. It's commoner if you've got curly hair, so you're more likely to get. I thought that was really interesting, and you're more likely to get folliculitis on your legs if you've got curly hair as well, apparently, because the hair comes out in a little spiral rather than poking straight out through the skin, so it's more likely to end up under the skin. And so if it's mild, they recommend topical steroid and shaving advice. More severe, you might need oral antibiotics. And then interesting, all the guidelines talk about the possibilities of using Vanaca or intense pulsed light therapy for it. Now, Vanaca we know is not something that our medicines management team are very enthusiastic about us using anyway. And IPL would very much be a prescription only thing, but I think if some people are getting it recurrently, it's just worth being aware that those are on the guidelines, and if you do end up persuading somebody to go and see a dermatologist privately, those might well be in the option list that secondary care come up with. Okie doke. So common childhood thing, which I have not seen any of this spring, much to my surprise, but I suppose that's because children are not going to nursery. So I've got one answer. Yeah, brilliant. So yeah, you're all right. It's chickenpox. And got some little, just worth seeing, vesicles on the palate, what vesicles on the palate look like, vesicular lesions, across the body, and a suitably sad looking small child in that picture. So obviously we know chickenpox is really contagious, and it's contagious, it's airborne and from the lesions. So that's the difference with shingles. You don't get the airborne respiratory droplet spread, it's just the lesions that are infective. Now, interestingly, this is how effective it is. If you are exposed to somebody with early chickenpox and you are you've never had chickenpox, you've got a 70 to 80% chance of being infected with the virus. So it is incredibly infectious. And of course, I think it's always also worth remembering, if we think about the quest for the New World and Vasco da Gama sailing across to South America, that's actually how they killed off the American population, the Native American population in South America, because actually they all came over with their infections, but particularly varicella, which absolutely decimated an immune naive population. And children usually aren't that unwell. Obviously, you can get secondary bacterial infection, and they can end up going on to get abscesses, cellulitis, and even neck fash and gangrene. What do we tell them not to give their children with chickenpox because of the potential increased risk of neck fash? Anybody know? Yeah, brilliant. Well done, folks. So yeah, ibuprofen. So Royal College of Pediatrics and Child Health prescribing people, everybody coming out there saying don't give ibuprofen. Now, of course, nobody really knows whether it is that actually just that the kids that were sicker with the higher temperatures that wouldn't come down with paracetamol, their parents gave them Brufen too because they were so pyrexyl and so miserable. And actually they were so pyrexyl and so miserable because they were already getting secondary infection, and nobody will ever know, but we are meant to advise people not, actively meant to advise them not to use ibuprofen. Thing of dehydration from vomiting and diarrhea, it can exacerbate that asthma. You can get chickenpox pneumonitis, you can get encephalitis. So it's not a completely benign disease, and it's much worse in older children and particularly in adults. So that's worth being aware of. And the other population that are really worth being aware of are children who are kids with childhood cancers that are having chemo. because their immune systems, even if they've had chickenpox once, they can get it again because their immune systems are so knocked off. And it's got something like a 50% mortality in kids on chemo, and that's why their parents are often so I mean, they're anxious about their child having cancer anyway, but while they're having treatment, so stressed about school, about waiting rooms, about who they're meeting up with, and any of those other things, just because of that enormously high mortality that you get there. And Public Health England says 5 days of exclusion from school or nursery. So 5 days and the lesions have crusted over. So if at 5 days they're still getting more lesions, they can't go back. If they've all crusted over on day 2, they've still got to wait till day 5. So it's 5 days and, not 5 days or. And vaccination is a perennial hot topic, or perhaps it's just a perennial hot topic in Wingworth because people want to spend their money on it. I don't know. But it's just worth being aware, obviously, that there is a vaccination. It is in the childhood vaccination schedule in Australia and in the States and in Canada, but not currently in the UK. Though, interestingly, if you are an adult and you go to medical school and in the UK and you are not found to be immune to chickenpox, I don't know whether the same is true of nursing students, but if you are found to be non-immune to varicella, you are via occupational health given vaccination now. So that's just sort of worth being aware of. And obviously, it's like I say, it's worse in adults. Also in pregnancy. So again, thinking if somebody has had chickenpox and they're exposed in pregnancy, their own immunity will protect their fetus. But if they are infected and get primary chickenpox in pregnancy, actually about 25% of the fetuses or babies will get infected. And it's just worth thinking about congenital varicella syndrome, which is rare, but is one of those torch infections. If people can remember back to learning about torch infections. If you get it, about 2% of fetuses exposed to varicella in the first 20 weeks can get congenital varicella syndrome, which is really very unpleasant. And again, newborns infected with varicella have about 30% mortality. So it's just worth being aware. So if mum gets chickenpox just before delivery or during the 28 days afterwards, her baby's at really severe risk of infection. And that's why they get given immunoglobulin if there is any possible chance that they are going to develop it. Okie dokie. So moving on, something else. I think some of those pictures are a bit more obvious than the others. Brilliant. Somebody's hot off the mark. Brilliant, well done. So people who've answered and said shingles, absolutely. So I suppose in some ways this bottom right is the most classical, isn't it, in terms of appearance, this cluster of blisters. Here more extensive, but of course following a dermatome. And I think one of the things that I would think about with shingles is always worth remembering is if it's going to affect a dermatome, it doesn't have to affect every single part of the skin area of that dermatome. So you sometimes see patients who'll come and say, oh, well, I've got this lesion on my chest and I thought it was shingles, but I've got one on my back too. So it's in 2 places, it can't be shingles. And actually, if you think about the dermatome, actually it's the same dermatome. It's just they've got a bit at the front of their, whatever, T6 dermatome or whatever, and a bit at the back. And actually it's within the same dermatome. So that's just worth thinking about. And again, prodromal pain, very, very common. So we can get caught out quite easily because actually they come with this really, really horrible stabbing pain. And we think it's musculoskeletal and we can't quite work out what it is. And then a few days later, they come up with a rash. And there's all sorts of triggers. So sometimes there are triggers like an injury of some sort or an infection or being run down. And there's quite a lot of stuff in the kind of anecdotal literature about COVID saying that we're seeing a lot more of it. And is COVID a really potent trigger of shingles? Or is it just that people who've been really sick with COVID are then really, really run down and then go on and develop shingles anyway? Not quite clear whether it's actually the COVID that's doing it. Just worth being mindful of the fact that just sometimes you can get multiple dermatome involvement or bilateral eruptions, so that's really unusual. Eye complications, so again, eye lesions, anything herpetic, whether it's herpes or zoster, if you've got it in the eye, you need to talk to ophthalmology. So I think that's just worth thinking about it. And again, you can get nerve palsies as well as a result, so that's just worth being mindful of as well. And I quite like sort of acronyms and mnemonics, so there's lots of A's in the management, so advice and avoidance for vulnerable groups, and if you talk to somebody with shingles, checking that they don't live with somebody who's having chemo or on really high dose steroids. Analgesia, because it's really, really painful. Acyclovir, 800 milligrams 5 times a day, so that's when we use the high dose acyclovir. Antibiotics if they've got secondary infection, amitriptyline for post-hepatic pain, and if they've got really, really severe pain, we're thinking about topical anesthetics as well. Okie doke. Something else, which we may all have seen quite a lot of, something that people tend to get in a bit of a tizzy about. Yeah, absolutely. Molluscum contagiosum. So really common, affects children, goes on forever. What is, before I flick on to my next slide, what do you tell parents when they say, how long is it going to go on for? Because it's one of my bugbears. And I'm being very mindful here. One of my registrars is here, and I know you don't do it because I've told you this already, but is people come, oh, I came to see another doctor, and they said it could go on for a few weeks. He's had it 6 weeks now, it hasn't gone away. How long is the average duration of molluscum? Yeah, it's about 18 months. 18 months. So, and if you say average duration 18 months, I mean, of course, some of them it'll go away sooner, and then they think it's brilliant because it actually didn't go on as long as you said it was going to. But I think otherwise they come because they don't know what it is. Somebody tells them it'll last a few weeks, then they come back in a few weeks because it still hasn't gone. Then you tell them it's going to go on for 18 months, and they feel a bit grumpy because somebody said a few weeks, and actually it's not a few weeks, it's 18 months. And then, unless you warn them about something, they come back the third time. And the third time they come back is usually over this, if you can see what's going on here, because usually before they go away, one of them perhaps gets picked or knocked or just goes a bit funny looking. They come, oh, it's got infected. He's had molluscum for ages and now it's got infected. And actually they just start looking really funny and go quite crusty. And then almost over the course of days, even hours, they just suddenly disappear. It's like it wakes up the immune system to the virus, and they go away. So I always use the British Association of Dermatology leaflet and give it to patients so that they've got that information, and point out that it will go on for 18 months and that the beginning of the end is usually signified by one starting to look a bit crusty and horrible, because actually that then saves 2 further consultations. So yeah, just worth thinking in adults, think HIV, because first presentation of molluscum in an adult is weird. It's not unheard of, but we are not very good at thinking about HIV. We're not very good at testing for HIV. And actually, if you've got an adult that presents with really significant molluscum, it probably is worth thinking, why has this person got molluscum? Is it just good old-fashioned bad luck, or are they more susceptible for some reason? And there is Moludab, which is available over the counter. It's about £14 a bottle. Nobody really knows whether it makes any difference. I think it makes parents feel like they are doing something, but it's not on our formulary. So we're not supposed to prescribe it. Okay. So this actually is a real patient photo and she's very excited at the idea that I was going to use this in some teaching, which is why this picture is here. And I'm going to ask you a question. Looking at this lesion, is there an occupation that this person might do that would make you pretty much 100% sure of what the diagnosis is? Brilliant. Well done. Yeah, farmers. So this is ORF. and don't see it very often. But the thing that was interesting with this girl is that she was about 18, farmer, and came in with this thing on her hand. She's like, I've got this awful thing on my finger. It just looks really, really awful. And she was wearing all her farm clothes and stuff, and said, well, I can't help notice the way you dress. And she said, oh, it's a nightmare. Yeah, lambing at the moment. I said, okay, if the lamb's got anything, she said, oh, it's a nightmare. The lambs have all got orf. And I was like, well, you've got orf. And she didn't realise that people could get orf. Where the other few times I've seen it, it's been people who've come and have kind of gone, I think this is orf. The sheep have got it as well. I just need to wait for it to go away, don't I? But I just wanted to check, was it anything else? Now, the thing that was really interesting with this is hers started off like that, and we talked about it being off and not a lot, but actually she ended up getting some complications. So weirdly, you get zoonotic transmission, so you never get human to human transmission. Brilliant pun. Thanks, Sarah. It was awful. It was awful because the poor woman actually got erythema multiforme. So it can cause erythema multiforme. So it was all quite kind of benign and, oh, just a funny little lesion when I took the picture of it. Actually, she ended up with a bit of lymphangitis and some swollen glands under her armpit, and then got erythema multiforme, and we ended up having to give her some prednisolone. So it's just being mindful that that can happen. And weirdly, they look like a pustule, but occasionally I've once seen somebody who thought it was like a pustule of some sort on their finger, and had incised it. And they said, but it's really weird. It looked like pus inside it, but there wasn't anything underneath. So they look like pustules, but actually there isn't any pus underneath it. And as I say, you just basically ignore them unless they get secondary infected, or if they've got really awful erythema multiforme and they're really unwell, in which case they probably need some steroids. Okie doke. So this looks a bit like ORF. It's another funny zoonotic thing. And is related to a particular hobby that this person has. If I tell you they kept lots of fish. Okay, no one, not even the person that gave me this. Ah, there we go. Yes, the person who gave me this slide. It's a fish tank granuloma. So these are caused by Mycobacterium marinarum, fish tank granuloma. They're uncommon. But again, if you see something funny, it's that whole thing about being really nosy. What do you do? Anything you think it could be? Do you have any hobbies? Where do you put your hands? Because actually, it will come. The history will come up. Oh yeah, I've been, I've got a new job working in the aquatic section at the garden centre, cleaning out the fish tanks, and they can take quite a while to clear, and it tends to be, they say elbows, knees, top of feet, knuckles or fingers, but generally speaking, the area that has been exposed in the tank. So if they've got it on their legs, it's more likely to do with the fact that they've actually been, in it up to their knees. But you can occasionally get some kind of bursitis and tenosynovitis associated with it as well. And obviously, if they're immunocompromised, as with most infective things in immunocompromised people, it can get a lot worse. Okie doke. So something else a little bit different. Again, 2 shots of the same thing in different parts of the body. Yeah, intertrigo. So Candida intertrigo. And just, we're thinking about, because I think we're almost more likely to miss it on hands. But actually, again, if it looks a bit cracked and a bit white and a little bit weepy, it probably is Candida. Where, this kind of, under the breast of somebody, sort of sweaty area, bit of redness, some satellite lesions, I think most of us go, oh yeah, that's all nice and straightforward. But sometimes you can be a bit foxed because of the lesion. Though weirdly, if that was between somebody's toes, I think most of us will go, yeah, that's athlete's foot, I can treat it. But it looks funny because it's on a hand, and then we get a bit confused and start trying to be a bit clever and think, is it something else? Is it something completely different? What is this? And actually, it's like if it was between the toes. So intertrigo is almost always Candida. occlusive clothing, gloves and footwear, so sweaty areas, obesity can be an issue. Don't forget incontinence. So just really, really thinking about irritant contact dermatitis and then secondary candidal dermatitis. So that's just really, really worth thinking about. Don't forget diabetes and immune suppression. So again, if you've got a reasonably fit, well, youngish person who is not obese and doesn't wear lots and lots of synthetic fibres and isn't particularly sweaty but keeps coming with recurrent candidal intertrigo, it's got to trigger off in the back of your mind, is there a secondary cause? And I think actually most of us think, oh, maybe they're a diabetic. And we're quite good at checking random blood sugars or checking HbA1cs. We are less good at picking up HIV, and it really is worth looking for. So treating them, clotrimazole or dactarin, and just thinking about those triggers. So actually good blood sugar control. So if you've got a diabetic with recurrent intertrigo, they've almost inevitably got a really raised HbA1c. So if you actually manage to persuade them to manage their diabetes a bit more effectively, they will probably stop getting intertrigo. And you know, if people keep getting athlete's foot, if you encourage them to walk around with no shoes on at home and get some air and some UV light to their feet, it makes an enormous amount of difference. So sometimes it really is the basic stuff that's really important. Okie doke. So on to something else. This one's perhaps a little bit trickier. So if I told you that that one came before the others, it might help. Yep, pityriasis rosea. Brilliant. And again, that's a kind of a close-up on a herald patch, which again, it can fox us, can't it? Because actually, if somebody's just got a herald patch and they haven't got the rest of the rash, you look at it and go, oh, is it discoid eczema? Should we give you some Betnovate? Oh, that's a bit weird, isn't it? Is it infected, or does it really look like staph? Oh, I don't really know what it is. And then, of course, a little bit later, when they go on and develop the rest of the rash, it's a lot more obvious. So it's probably viral. No one really knows why. And probably something to do with HHV6, which is the virus that causes roseola infantum in kids. It's more common in teenagers and young adults, and you get that Christmas tree distribution in the Langer's lines. Just worth thinking about, the vast majority don't itch, and all the books say it's not itchy. Take it from me, I had it, it was unbelievably itchy, and it was so unbelievably itchy, I did a literature search about the itch in pityriasis because it drove me bonkers, and actually it's either intensely itchy or not itchy at all. And most people don't itch, but yeah, if it looks like pityriasis but it's itchy, it's still pityriasis. Lasts for about 6 to 12 weeks. There's no treatment, and there may possibly be an association with miscarriage in the first trimester, though there is no really good quality evidence on that. And of course, actually, when somebody has a miscarriage, they're usually thinking desperately, is there something I did? Could there be something that caused it? What on earth's going on? They remember the fact they had pityriasis and they put the two together, and actually it might just be that theirs was one of those 1 in 5 pregnancies that wasn't going to make it. So if somebody comes with pityriasis, you know, who is pregnant, there is no need to be overwhelmingly doom and gloom about it. But as I say, there might be an association and they may be worried about that. Okay, so another rashy thing. Brilliant. Everybody's really good at dermatology. I'm relieved and impressed. So yeah, so this is pityriasis versicolor. And just worth thinking about versicolor, because you've got your pink version here, your brownish version here, and then of course here, where it goes, where you get the depigmentation because of the effect that it has on the melanocytes. And it's not uncommon for people to start off with a pigmented lesion and then go in the UV light, and that's taken out their melanocytes, and then they come with this white, weird, scarry thing. And, you know, not uncommon for people to come and say, oh my goodness, I think I'm getting vitiligo, I'm so worried. And actually you can be really reassuring to say, no, actually, I don't think you're getting vitiligo. This is something that's treatable. I love the fact that, well, it always used to be called Malassezia furfur, but they've now decided that Malassezia is a species and that there are a variety of strains of Malassezia. I just think it's a brilliant name. So this is where we use ketoconazole or selenium sulfide shampoo. And again, where those bad leaflets are really, really helpful. Because the number of people I've had who've rung up and said, oh, I don't know, oh, I saw somebody with this rash and they sent me to the chemist for something and I've come home with some shampoo. That can't be right. Why do I need to wash my hair with it when it's on my body? So actually going through what it is that you're meant to do with the shampoo, and the fact that you apply it to the entire affected area at bedtime and do not wash it off until the next morning, and putting that, and I know ketoconazole and selenium sulfide are both over the counter, and you're meant to be able to buy them, but then it's really important to write down the instructions for what they're actually going to do with it when they get it home, because of course the packaging will talk about using it for dandruff, which is not why they're using it. Now it's really weird, you can use terbinafine cream for pityriasis versicolor if you want to, so Lamisil cream, but you can't use the tablets. That's really bizarre. And it's not just because terbinafine is quite toxic and quite horrible and we kind of reserve them for people with stuff that really won't settle. It doesn't actually work, which I find fascinating if it works topically. I don't know why. If anybody knows why, feel free to tell me. Just one of those weird facts. But so if they've got really, really significant pityriasis versicolor and it's not settling, you're going to need to give them oral fluconazole, not oral terbinafine. Okay. So I'll give you, perhaps you might want a little bit of history with this one. So this little boy has been feeling a little bit under the weather for a few days, a bit miserable, had a bit of a temperature, and he's now come out with this rash on his cheeks and on his arm. Slap cheek, fabulous. Brilliant. What causes slap cheek? Anybody remember? So slap cheeks caused by parvovirus, and it's also known as fifth disease or erythema infectiosum. And you get that, they talk about their lacy or reticulated rash. So this is where, you know, dermatologists love weird mumbo jumbo, don't they? Funny phrases. But reticulated, can you see that sort of lace pattern? So reticulated is meant to mean lacy. So the sort of lace pattern rash on the arm there. And they get the classic slap cheek on their face. Kids tend just to get slap cheek and have a bit of temperature. They tend to be better once the rashes come out. And interestingly, you're vastly more infectious before the rashes appeared than when the rashes come out. So I always think that's just you know, worth being mindful of. But actually in adults, you can get really quite marked arthropathy. So you can get a sort of synovitis picture that goes along with it. We're thinking if people have got autoimmune hemolytic anemia or sickle cell, it's a fairly potent cause of a sickle crisis. So that's just worth being mindful of. And you can get all sorts of problems in, again, people with immunodeficiency, people on anti-rejection drugs can be a really, really scary thing. Just worth thinking about pregnancy and high-risk people and doing the serology. Simply because actually if you get slap cheek, or if you're exposed to parvovirus, infected by it during the first half of pregnancy, there is about a 3% chance of hydrops, so fetal heart failure, a 9% risk of intrauterine death in that first trimester. It doesn't cause any congenital malformation. So essentially, if they get to the 20-week scan and they're fine, then it doesn't matter. The time has gone. If they're exposed to it in later pregnancy, it's not an issue. But it is something that I think, depending on who the community midwife is, I not uncommonly get people ringing up saying, "Oh, I'm a teacher, or I'm a midwife, I'm a nurse practitioner, I'm a GP." I'm pregnant. I was just wondering, could I have parvo serology done, because I think it's going to have a bit of an impact on how much I'm going to worry through the beginning of my pregnancy about being exposed to children and children with rashes, and counselling them. And I've got an incredibly low threshold for saying, okay, well, let's do serology. If you are immune, then that's great. If you're not immune, I don't think I can then give you a sick note for the rest of your pregnancy. So actually, how are you going to risk manage? But it is worth thinking about, because actually they will feel enormously reassured if they have actually got antibodies. So I do think it is worth doing for those people if they ask nicely. Okay, so this might look slightly similar, but it's something slightly different. And yeah, I was going to say no children have been harmed in the making of these slides. This is my daughter a few years ago, who was slightly excited about the opportunity of being used for some medical education. So this was an unseasonably warm Easter and a very, very well 4-year-old. And it was quite itchy. And if you have a look, it's not great, it doesn't come out very well there. The top of her arm, she's rolled up her t-shirt, because where her t-shirt went across there, you haven't got any rash. You've got it all down her forearms and all over her cheeks. Yeah, so it's photosensitive. Do you know what sort of photosensitivity? It's got a name. Yeah. Yeah, well done, Pauline. So yeah, it's solar urticaria, or juvenile spring eruption, which is a form of polymorphic light eruption. And it's a delayed sensitivity to UV light, and you classically only get it in the UV exposed areas. So face, forearms, tops of ears. And it's the one that people often sort of say, oh, they've got really itchy ears. And teenage boys that go skiing, suddenly really, really itchy rash over the tops of their ears, and they get exposed. And it looks a lot like slapped cheek unless you take the right history. So that again is, you know, one of those kind of caveats in dermatology that, yeah, there are some gestalt diagnoses, but sometimes the history is everything. And so you are supposed to use high factor SPF and graded exposure to the sunlight. And that's where the difference between a true polymorphic light eruption, they get it with every single exposure to UV. Where with juvenile spring eruption, as it says, it's in the spring, it's the unusual exposure to the UV light in skin that's been covered up all winter. Suddenly it gets really sunny, or suddenly they go off in spring half term and go skiing and are really exposed to some UV, and then they get this kind of allergic reaction, and then with a phased graded exposure to sunlight, it stops. Okie doke. So this actually is our last one. And again, this is a tricky one. So this is probably, I think, probably the hardest one. And I've put those there because they are all the same thing, though I suspect nearly all of us, if we saw this, would probably not jump straight to the diagnosis that you might get maybe with that. Yeah, awesome. Well done, Pauline and Linda. It's granuloma annulare. Really easily missed. And actually, I think often made almost as a bit of a diagnosis of exclusion, because you see this, and I don't know about you guys, but I think I look at that and go, oh, it's fungal. So we've all given them some clotrimazole, or perhaps we've hedged our bets and we've given them an antifungal with a steroid, which actually can often make granuloma annulare better anyway. So in some ways, does it matter? But it's just worth kind of thinking of, because actually patients love it when they've been 2 or 3 times and somebody gave them some steroid and it didn't get better, and then somebody gave them some clotrimazole and it didn't get any better, and then you get up dermnet and go, oh, I just wonder, could it be granuloma annulare? And they suddenly think that you're really clever, and actually it's not. It's just because you've done it as a diagnosis of exclusion. But it's just worth being aware of it, because as I say, it's not that common. But I think we do miss it and we think it's fungal, and then they get a bit despondent and keep coming back and aren't getting any better. And actually what they really need is just to be left well alone and wait for them to go. And you can get the localized form, which you get more likely in children, which is the sort of the bumps are more likely to be over the knuckles, or the backs of the hands, or over the feet or the ankles, kind of over bony prominences, where the generalized form, you get the bigger patches, and you can often get them around skin folds. And again, because if you're going to find them in the armpits and the groin, again, you're going to go, oh, it's fungal. Oh, it's a sweaty place. It's probably fungal. So again, one that I think is really, really easy to miss. And I'm not for a moment saying, oh, everybody ought to, nobody's any good at diagnosing granuloma annulare. Absolutely not. It's just, it's quite nice if you do bear it in mind. It can actually make you feel quite clever if you get it. So that's kind of where we're kind of at, and sort of the end. So I'm going to unshare and see if anybody wants to say anything or do anything. But as I say, if you are somebody that is a total activist and thinks, if I'm going to do some feedback, I want to do it straight away, I want to do it now, I've played around, you've got a QR code, you can scan it on your screen and feedback immediately. If not, there is a Survey Monkey, and I will send that out to people, and I would really appreciate knowing what people have thought. And I've just put that date again in there for next time. So I'm going to take that off the share and come back to you all. So thank you for your time and patience. Any thoughts or questions? So Naren's just put in the chat, absolutely. So Naren was going to collate the email addresses. So some people gave you, people who were here early did put some email addresses at the top. If you want to stick your email address into the chat, that would be hugely helpful, and then we know that we can send the feedback and stuff out to you. So any questions, feel free to unmute yourselves. As I say, I'm not an expert, but we have got lots of people here, so there probably are people who are reasonably expert at dermatology, and who might have some answers if anybody's got any thoughts or any questions at all. No, everybody's very quiet, but a few comments on the chat. What do we think? As I say, I've kind of gone, oh, let's do some HRT next time. Does that sound a sensible topic?
Yeah, definitely.
Yeah, definitely. Okay, so we will do some HRT next time. And anybody, as I say, if people do want to volunteer, take over, I think it'd be really nice if we are in a situation where, as a PCN, we feel like we are, providing some good free access medical education to people within our teams. So for people to, volunteer to run some sessions at some point. Like I said, we'll do HRT next time. I've got Steve Lloyd from the CCG with Duncan Gooch and Sid Chawla, who's our PCN clinical lead, going to come and talk about 3-letter acronyms and what they mean for us and our patients in 2020. So I hope that might debunk some of the myths and actually make a little bit of sense for any of these other things. Yeah, so any ideas for future topics, whether or not they're things that you want to present, please let me know. That'd be much appreciated, and thank you very, very much for coming.